Is Dr. Angela Hogan, and I'm a pediatric allergist at Children's Hospital of the King's Daughters in Children's Specialty Group and also at Eastern Virginia Medical School. Tonight we are going to discuss the topic of off to school we go, keeping the food allergic child safe. I do want to note that I have nothing to disclose. I have no payment for this lecture, and I don't have any financial interest other than I have an interest in keeping kids as they go back to school safe. A little bit of housekeeping before we get started. This presentation will be recorded and posted on the FASGOT website, hopefully in the next week or so. Please note that for maintaining a quality recording, hopefully I am correctly muting all people as they enter on the website. And if not, you might just touch your mute button too, just to make sure that we don't get any extra sounds. This is the first time I have ever done a WebEx meeting, so I'm hoping that I am mastering technology well enough. Also, if time permits at the end, I will respond to questions. I am able to see questions as they come in, so if you want to type your questions as we move along, at the end of it, hopefully time will permit, we'll be able to go ahead and answer some of those questions. So let's go ahead and get started, and we're going to talk about how we keep the food allergic child safe at school. So I like this. This is from Allergic Living, which is one of my favorite websites. And it basically summarizes what we would hope for children that are attending school with food allergies. This particular child wants to tell you that they do have food allergies, which can be a serious medical condition, and it wasn't their choice to have food allergies. That 1 in 13 kids actually have food allergies, and while they may look normal, they're normal because they haven't been exposed to their allergen. And if they were to accidentally eat their food allergen, they could end up in the hospital with a severe allergic reaction called anaphylaxis. But these kids, your kids, my kids, they still want to be normal, they want to be included, and they want to be able to play with other kids. And many of you all probably know I did have a peanut allergic son who has outgrown his peanut allergy, but I understand many of the aspects of trying to make sure that he's safe at school because I have been through it myself and can appreciate the concerns that you have tonight as a parent getting ready to start off to school next week with your child. So let's do just a little bit of semantic review so that everybody's sort of on the same page and we're sort of talking about the same thing. Tonight, when I talk about food allergy, what I mean is an adverse reaction to a food allergen that's caused by an immunological mechanism. It's reproducible. It should happen, although it may happen to different degrees, each time we see an exposure to the food, and the immune response can be severe and can be life-threatening. We usually talk about these in scientific terms as being type 1 allergic reactions or IgE-mediated reactions. So tonight when we think about food allergies, that's what we're going to be talking about. What is actually anaphylaxis? Anaphylaxis is the most serious allergic reaction. It can be very rapid in onset and as you may very well know, it actually can cause death, although that's not very frequent. The most common causes of anaphylaxis are foods or medications, sometimes stinging insects. Also, latex products have been associated with anaphylaxis. Sometimes we have children in our practice that have anaphylaxis due to cold exposure. Sometimes we have patients that have anaphylaxis because they exercise, or maybe they exercise and they eat food. And also there are people that have anaphylaxis for unknown reasons. So how common are food allergies? Well, we know that more than 15 million Americans actually have food allergies. That is 8% of U.S. children have been diagnosed with a food allergy. That's 1 in 13 school-aged children, or actually 2 kids per classroom these days. Those of you that are a little bit older parents know that probably when you were in school, there may have been almost no one with food allergies. And to be at the point where we now have 2 kids per classroom with food allergies is quite significant. And we are in a food allergy epidemic. And we'll talk in just a minute a little bit about why we think we may be in that epidemic. And of those that do have food allergies, 30% of them are allergic to multiple foods. So, again, how common are food allergies? Food allergy diagnosis has increased approximately 50% from the years 1997 to 2011, according to some statistics that were released by the CDC. But even more alarming, actual anaphylaxis has increased by 377% from the years 2007 to 2016. There's a new report that has a lot of demographic and epidemiological information that's put out by a nonprofit group called FAIR. And FAIR is a collection of health private insurance claims from a very large network of insurance companies. And 377% obviously is a significant increase in the number of anaphylaxis cases. From that same independent nonprofit group that collects data, you can see here on this graph that there is significant increase in the number of anaphylaxis here. And even in the last 2 or 3 years, we're seeing significant increase in the episodes of anaphylaxis. So what are the most common foods that individuals who have food allergy are allergic to? The 15 million Americans are allergic to a wide range of foods. According to labeling laws, there are 8 foods that are supposed to be on all food labels if those foods are contained in that particular product. And this is just sort of a breakdown of how common those foods are. 25% of individuals who have food allergies are in fact allergic to peanut products. You can see here that 21% are actually allergic to milk. Milk is certainly a food that doesn't get nearly as much press as peanut does, but it is one that can be significantly hard to cope with because people don't think about cross-contamination or the splattering of the milk carton that might happen at the lunch table. You can see here shellfish makes up about 17%, and we're going all the way down to where actually wheat allergy is only about 5%, and soy allergy is about 4.6%. So multiple foods, and remember that I said as many as 30% of individuals who have food allergies are allergic to more than just one food. So from also the data from the FAIR group, what are the most common foods that they found for anaphylactic reactions? You can see here that a large percentage of those reactions were actually to peanut, about 26% of them. Tree nut came in second at about 18%. And because these were health claims, there was a large percentage of them that they weren't quite certain what the allergic reaction was to. Perhaps maybe the individual had not gone yet to an allergist or had not had blood work done yet to determine what was the cause of anaphylaxis. And you can see here the breakdown to other foods. And surprisingly, anaphylactic reactions to milk are small, only about 5% for a food allergy that 21% of individuals are allergic to. So I found that very interesting. But again, nuts seem to be the biggest culprit for those allergic reactions. And also, from the data from this independent collection data agency, they broke down how often we saw food allergy diagnosis by age. And you can see here, as we all know, the large majority of individuals who are diagnosed with food allergy are usually under the age of 3. And then we still see some increased diagnosis throughout childhood, and it's much more unusual to have a diagnosis of food allergy as we get into our late 20s or older. Usually in childhood, we see those diagnoses of food allergies, usually peanuts, milk, egg, wheat, or soy. In later life, usually it's shellfish and tree nuts that tend to be the most common allergens at that time. So, what's the natural history of food allergy? Children are much more likely to become clinically tolerant to soy, wheat, milk, and egg. As you know, peanuts, shellfish, and tree nuts, as well as fish, tend to be more lifelong. But many studies are demonstrating that as many as 20% of kids with peanut allergy may, in fact, outgrow their peanut allergy, and about 10% of individuals who have tree nut allergies will actually outgrow it. It's a much smaller percentage of shellfish and fish allergies, assuming that they have the correct diagnosis and that they had clinical disease. Oftentimes, we'll either use blood tests or skin tests to decide whether or not they have or whether or not they have sensitization. But the story and sometimes food challenges are what we need to do in order to determine if it's truly clinical disease. We also know that skin tests can remain positive for many years, even after they're eating the foods. And sometimes the size of the wheal will help us determine whether or not they're still allergic to the food. But don't think that the size of the wheal that tells you how severe the food allergy is. It does not do that. Oftentimes, we'll measure specific IgE to the foods, and individuals who have high IgE levels to the food oftentimes are a little bit slower to outgrow that food allergy also. And there's no cutoff period. I've had some kids who have outgrown their food allergies in their 20s, if they're still considered kids. So we do see the majority of food allergies outgrown, usually in elementary school and middle school. But again, like I said, I have had some kids not outgrow their food allergy until their 20s. So, why is food allergy on the increase? Well, that's an excellent question. I get asked that all the time, and there's lots and lots of theories. It probably is not a genetic issue because if you think about genetic changes really take thousands of years for a population to make a genetic change. It probably is more of an epigenetic change. And what epigenetics are is that changes happen to our strands of DNA where we stick on maybe a methyl group or make some change. I like to think of it like turning off and on switches. We really didn't change the switch plate that's on the wall. We just decided which switch is going to be up and which switch is going to be down. Those are the kinds of changes that happen due to external exposures. For example, a good example is like if you smoke during pregnancy, then you are much more likely to have a child that may have asthma. It's not that you changed their genetic makeup because that was already done by the time that they were in your womb, but the fact that you smoked changed exactly how the genes may be expressed, and that's why they're more prone to asthma. In terms of food allergy, one of the things that's getting a whole lot of attention is the hygiene hypothesis. And I'm sure most of you all have heard that we think because we use so much hand sanitizer and because we vaccinate so much that maybe our immune system is bored, and because of those things, it doesn't know what to do, so it decides to make food allergies instead. That's probably a simplistic view and probably doesn't quite cover everything. A lot of people think it's changes in our environment. There are a lot of individuals that think we're really not in an allergy epidemic. We're just doing a whole lot more testing and that we're just more aware of it, and it's really not a real phenomenon. There was a lot of concern that we were waiting too long to introduce foods to infants. For those of you that might have older children that may be over 10 or so, you remember initially we told you 10 years ago that you should wait to introduce peanut or tree nuts until after the age of 2 or 3, and that we shouldn't introduce eggs until the age of 2. And we know from some very good studies that have been published in the last year or so that probably was not the best advice. We now know that early introduction of foods is very important if we're going to capture a time in the immune system when we want the foods to be tolerized instead of sensitizing. We know that sometimes changes during pregnancy or delivery are associated with higher risk for food allergies. For example, the child that is born vaginally has a less risk for food allergies than the child is born by C-section. C-section babies have about a third higher rate of food allergies than vaginal deliveries. We also know that moms who take a lot of antibiotics during pregnancy are a little more prone to food allergic kids. There's also some discussion that things like probiotics or fish oil can be protective during pregnancy and may reduce the risk for food allergies. All of this sort of plays into what I think is probably the best theory, and that has to do with our gut bacteria. It's a very popular discussion point right now that how you colonize your gut really determines your immunological future, and the more and more diverse bacteria that you have in your gut, the more food friendly your gut is, and the less likely that you are to have food allergies. And that makes sense for babies that are born vaginally versus C-section. When you come through the birth canal, you get lots and lots of bacteria, and obviously in a C-section, it's a much more sterile environment and you have a lot less bacteria. The same thing with breastfeeding. We know that you colonize the gut with good bacteria. So there are about 20 more reasons for why we might be having an increase in food allergy, but we do know we're in an epidemic of food allergy, and in the last 20 years, we've seen significant increases in food allergy. So, what are the statistics in terms of food allergy occurrences? We know that every 3 minutes, someone goes to the ER with a food allergic reaction, and that food allergy is the leading cause of anaphylaxis outside of the hospital. There are about 200,000 ER visits per year, 10,000 hospitalizations per year, and fortunately, because they get appropriate therapy, only about 150 to 200 deaths per year. So I think that if there are 200,000 ER visits and only 200 deaths, that's very encouraging for our awareness in this country about food allergies and our ability to use auto-injectable epinephrine early. As we know and discussed just a few minutes ago, the most common reactions are peanuts and tree nuts, and those are also the leading cause of the most severe reactions, and shellfish is also included in that group. So when we talk about food allergy, there are some key facts that we should keep in mind as we prepare ourselves to send our children to school. The first fact is that food allergy is an overproduction of an immune response to a food protein, and it can affect multiple systems in the body. Even a small amount of the food actually can cause an overreaction, and some of the frustration that parents ask me is, well, how much does it take to make them sick? We really don't have any good scientific methods short of a food challenge to be able to say, oh, it would take 3 peanuts to make them sick, so you're safe if you only have 2. We really don't know anything about threshold levels at this point in our understanding of food allergy. So we treat everyone as if a very small amount can make them sick, so we try to do strict avoidance, but in reality, we don't know the answer to that. We currently know that there is no cure for food allergies, but I'll put an asterisk to that because there are multiple methods for either inducing desensitization or ultimately oral tolerance that are being studied. And we'll talk about that at another meeting here on our webinar. But for right now, the general opinion is that strict avoidance is the safest way to prevent a life-threatening reaction. We also know that an allergic reaction usually occurs within seconds to minutes after the ingestion, but sometimes can occur 2 to 4 hours after the ingestion. That's usually based on what kind of food is in the stomach. Sometimes if you've had a really fatty meal, there may be delayed absorption of that particular allergen. And then again, it's a topic for another time. There is also the delayed red meat allergy that we are seeing in some children, and that has usually the presentation of the food allergy reaction happens about 6 or 8 hours after ingestion of red meats if you have that allergy. We also know that the severity and progression of an allergic reaction is unpredictable, and prompt administration of epinephrine is critical, and sometimes a second dose of epinephrine may even be necessary. So, what are the signs and symptoms of anaphylaxis? They can be throughout the body, and we usually consider anaphylaxis to involve 2 different systems happening at the same time. And these are things I know that all of you all know, but we're just going to review them for a second. Commonly, what we see is skin involvement that actually involves usually itching, or we also see, I'm trying to get the pointer to work for me there. There we go. Oftentimes we'll see hives, we see itching, we may see flushing. In addition to that, we can see accelerated heart rate. In the most severe cases, we may see a drop in blood pressure, but in pediatrics, that's usually a later finding. We also can see swelling of the lips or an itchy throat or tongue. Obviously, in the more severe cases, we can actually see loss of consciousness, and we see the respiratory tract involved a lot. They may have shortness of breath or wheezing. Cough is one we see very often also. And also in the GI tract, vomiting is probably the most common thing we see. Occasionally, there can be loss of bladder control, especially if there's loss of consciousness. So those are the main signs and symptoms we see for anaphylaxis, and also depicted another way in this schematic here. Again, anaphylaxis typically involves two organ systems, and the most common organ systems we see in pediatrics are skin, the GI tract, the respiratory tract, and cardiovascular systems. So I do want to make a quick point here about what is the frequency of symptoms that we see in anaphylaxis. Sometimes individuals are told, well, first you'll see hives, and then if they have vomiting on top of it or cough on top of it, then that would be two systems, and we'd want to go ahead and use our auto-injectable epinephrine. But I do want to point out to you that actually 12% of the time we don't get hives. And I believe, and there are some studies to support it also, that it is in those instances that we delay administration of the epinephrine because we don't get hives, and sometimes those are associated with more significant poor outcomes. So I always tell the school nurses when I give talks to them that allergic reactions can present with just wheezing and vomiting or two other symptoms that are not just hives. So don't say it's not anaphylaxis if you don't see hives. So, as you know, we all say that emergency medications need to be present at all times because we really never know when an accident is going to happen. Obviously, if we knew the accident were going to happen, we would try to prevent that. So there are multiple kinds of auto-injectable epinephrine that's available, and I'd like to spend just a couple minutes here just updating you on a few of these. The standard one that most individuals have had over the years is the Epipen. As you know, it comes in two different strengths. It comes in a 0.3 milligram dose and a 0.15. In our practice, we usually change over at about 52 pounds or 25 kilos. This was the standard one that we've used on the market for years, but in the last 4 or 5 months, a generic form of that medication has come out from the exact same manufacturer. It looks exactly the same, and it is the same other than it doesn't say the word EpiPen on it. It's about a third of the cost, so there are a lot of insurance companies that are now asking for the generic form of the EpiPen. If you haven't looked lately, your package insert has changed in terms of instructions for using the EpiPen. You no longer need to hold it for 10 seconds. The package insert actually says 3 seconds. I personally am telling my patients 5 seconds because I think in the heat of the moment I probably would go 1 to 3, which probably would be a little bit quick to give the medication. But the package insert does say 3 seconds now. For those of you that remember the old videos where your arm is raised almost over your head and you come down into your thigh with a swinging force, you no longer need to jab the leg with the auto-injectable EpiPen. The new instructions say that some firm pressure, a little more of like a mild stab, if that's a good word, would be enough force that would be able to administer the dose. In addition to that, there is generic auto-injectable epinephrine that's available. This is the old Adrenaclick that has now come out in a generic form. It is still 10 seconds, and it is a 2-step process where you remove the 2 separate pieces, And when it is done, you do still see the needle, so it will need to go back into the case to dispose of that. And then in February, AviQ, another form of auto-injectable epinephrine, returned to the market. For those of you that remember this medication, it was recalled about 2 years ago due to some concerns about the medication may not have been fully delivered in a few cases. So the manufacturers of this particular medication went off and formed a brand new company and fully automated their production. And then ultimately, the FDA came in and said, "We love it. It's all good." And it's available on the market too. There are pros and cons for all of these types of epinephrine, and you should talk with your allergist or your primary care physician who's prescribing it over which one would be the least expensive, and also which preparation may be the easiest for your child to manage or to carry. So, moving on then about epinephrine, I do want to remind everybody that if we are having a systemic allergic reaction, that epinephrine is the drug of choice and not antihistamines. Antihistamines are only the second line of therapy. I like this quote from Dr. Carnargo, which says, "Benadryl is what you give to patients so they don't itch while they die of anaphylaxis," which is meant to say don't use Benadryl to treat anaphylaxis. You can use it to help control the itch, but really first-line therapy for anaphylaxis is in fact your auto-injectable epinephrine. So let's talk just a moment about what is epinephrine. It's basically a hormone that we already have in our body. It's adrenaline. How does it work? It basically helps open up the airways that might be constricted or tight because of the allergic response. And it also helps tighten up blood vessels so that we don't leak fluid into the tissues and have continued hives and also swelling or angioedema. The most important thing is to give it early. And we know that once the allergy cells have gotten irked and start dumping out all of their mediators of the allergic response, that it is much more difficult for epinephrine to turn that off if we get further and further along the episode of anaphylaxis. So we like to make sure that you give it early. And the other thing we like to make sure is that you have a second dose of epinephrine available. Recent studies have suggested that 1 in 8 children actually need a second dose of epinephrine for their food-related anaphylaxis. So that's why 2 doses usually come together when you get your prescription for auto-injectable epinephrine. In addition to that, one of the things that I recently came across was an article that discussed why patients don't use their auto-injectable epinephrine when the physician felt like it may have been important to use. One of the overwhelmingly common reason was because the actual medication wasn't accessible when the reaction occurred. So it was somewhere else when they had the allergic reaction. They also didn't use it because they gave Benadryl, for example, first to see if perhaps maybe that would cover the reaction. I oftentimes have families not use the epinephrine because they don't want to have to go to the emergency room. They know that the instructions on their action plan says if you use epinephrine, then you should go on to the emergency room, and they don't want to have to do that, so they'll try and get by with Benadryl first. Or I even sometimes have families who, in fact, do use the epinephrine and don't go on to the emergency room. The reason we want you to go on to the emergency room is because you may need a second or a third dose of epinephrine. The allergic reaction may be escalating, and you want to be somewhere where if you need fluids or additional support, those medications can be given. And also we know that when you have an allergic reaction, sometimes you can have what we call a late phase reaction, which means that everything can be looking really good, and maybe within an hour or 2 of the initial allergic reaction, the child may have another anaphylactic episode without eating any more food at all, and that may be related either to the response of the immune cells or perhaps some of the additional food that was in their stomach was then absorbed and caused them to have a second wave of the reaction. The second wave reaction can be pretty scary, and that's one of the reasons why we would rather you be in an emergency room so that they can handle that reaction if it happens. Other reasons why patients reported they did not use their auto injector is they weren't quite instructed very well. They weren't sure when to use it. I've had several families who have come to me and I asked them, when would you use the auto injector epinephrine? And they say, oh, well, we're supposed to use it if the child's lips are blue, which I would certainly hope that we would be encouraged to use it much sooner than waiting till the child's lips were blue. But they have been instructed that it's a last resort medication and that you should wait to make sure that's the last thing that you have to do before you give that medicine. I'm not really sure why so many individuals are afraid of epinephrine. I tell my families that every single month I have a parent who accidentally sticks themselves in the thumb with their auto-injectable epinephrine. And the only thing that happens to those parents is that their thumb is sore. And because they're not having an allergic reaction, they don't have to go to the emergency room. So I think we should encourage, as we send our kids to school, the other individuals that are going to be responsible for taking care of our child. We should encourage them not to be afraid of epinephrine. We should make sure they're comfortable with the devices. And we'll talk a little bit more about that in just a second. And you should be comfortable with the epinephrine too, because it's important to treat the reaction. A couple of years ago, we saw a lot of individuals who didn't have Epipens or adrenal clicks because they were not affordable. They cost so much money. Fortunately, through a lot of rebate coupons and things that are available now, they're much more accessible. And sometimes the physician didn't prescribe an auto-injectable epinephrine for the allergic reaction, so the patient did not have it to use because they hadn't been prescribed it. So let's now move on just a little bit and talk about the school situation. I find it very interesting that almost 20% of kids have had an allergic reaction at school, and that actually about a quarter of those reactions that happen at school, it's the first time ever they've had an allergic reaction, and no one knew that they were allergic to that food until the reaction happens at school. So we're very fortunate here in the state of Virginia that all of the public schools have stock epinephrine available just for that reason, for kids that might have an allergic reaction that was not anticipated, or a child that allergy was not anticipated. Again, allergic reactions are never anticipated, but they have stock epinephrine available for those childs that have a new allergic reaction, and they also have extra doses that would be there in the event a child were having anaphylaxis and needed more doses than what they had brought to school. I think it's reassuring to know that the majority of food allergic reactions in school are not anaphylaxis, and again, deaths are rare. We see more anaphylaxis in the preschool age kid than we do the older kid, and that may very well be that the older kid may immediately sense that they have bitten into something that has their allergen, and they may be more prone to spit it out, or they may be quicker to be able to go to the school nurse and say, I don't feel well, or my symptoms are beginning, whereas the preschool child may have some barriers to communication. So, when we're talking about going back to school, we want to work on building a team that involves everybody that will be there to help take care of your child while they're at school. So, I have made for you what I call 6 steps for a successful school year, and we are going to review what those 6 steps are, and hopefully as you get prepared to go to school next week, these will be helpful for you. So, the first thing that I think you should do is get your stuff in order. So, you need to go to your primary care provider or your allergist and make sure that you get all the things that you need in order to take to school. So, what sorts of things do you need to take to school? Well, you need to take an action plan to school. In this particular area, we use this form here, which is the life-threatening allergy management plan that has been developed here at CHKD and in conjunction with several of the area schools also. And basically, for those of you that have this plan, you know that It reminds the school of what your medications are, what to do if there's a few hives, and it reviews again that if two things are happening at once, that we want to go ahead and give the epinephrine, and that a second dose can be repeated. One of the things that we added to this form a couple of years ago was that if your child is given epinephrine at school, then it's an automatic transport onto the emergency room. Occasionally, the school nurse would administer epinephrine prior to this statement, and by the time the EMTs got there, the kid looked really good, and the EMT said, "Oh, we don't need to transport them. They look really good." And we really wanted to override that again because you can have that second wave of the allergic reaction, and we wanted to make sure that the children were in a safe place. This is the school plan that actually is available through FAIR. FAIR is an outstanding website that has lots of useful information about food allergies. FAIR stands for Food Allergy Research and Education, and this is a standard school form that's used throughout the country, which very similarly reviews what are mild symptoms and what are more severe symptoms. And in our area, both of these forms are used. And then the other thing you need to do is if your child does have asthma also, you want to remember to get an asthma action plan to take to school as you go to school next week also. In addition to that, you need to get your medicines to school. So I include the medicines as part of your stuff. You need to make sure that they're not expired or will be expiring soon, or the school nurse will certainly give you a phone call. You need to make sure that you've talked about, at least to the people as you bring the stuff to school, where will those medicines be, and also how quickly will they be accessible. And then you need to also talk with your doctor about, is this a child who might need to have a self-carry form, which is available, which says that the child will have auto-injectable epinephrine with him throughout the day and also for after-school activities. And then as we talk about, we want to make sure that you're trained on how to use those devices so that you can go ahead and share that information with the individuals that you'll need to show how to use the medicine and get them prepared. So that is number 6, get your stuff to school. Number 5 is go meet the school nurse. Go talk to the school nurse. And there are several questions that I have proposed that you should talk with the school nurse about. So you want to know at your school, when is the school nurse actually present at your child's school? Are they full-time? Are they part-time? Are they available by phone? So you want to know if there's lapses of time when there may be someone else you need to make sure is able to administer the epinephrine if you need to. If the school nurse is not at school, who takes care of the students during the day, especially if they're sick, and if there's actually a school nurse room that the school nurse is in, what happens when she has to go to the bathroom? Does the medicine get locked up? Or just kind of the everyday practicality of where is my child's medicine going to be and who is going to be there to be able to give it if we need to have it. And one of the things that you want to make sure is that your child's medications are not locked up in whatever school that they will be attending so that they can be rapidly accessible to use in the case they might be necessary. Other questions that you may want to ask the school nurse: does the school have any experience with food-related emergencies? Is it something that they've seen before? Do they need to huddle together much like they do for a tornado drill or a severe weather drill? Do they need to think out who's going to go and get the auto-injectable epinephrine, who's going to stay with the child, who's going to be present to calm the other children who are concerned about the allergic reaction that may be happening in this child? They need to have thought through those things. So you could ask the school nurse, have they thought or discussed about that? And do we need to have a mock drill so that, in fact, the school may be prepared? Most of our public schools in the Hampton Roads area actually for several years have been doing a lot of anaphylaxis education, and most of them are very savvy and have practiced these sorts of emergencies. But you want to know, again, if there were other things that were going, if the school were evacuated or if the school were on lockdown, where would medications be available in that case? And then you want to ask the school nurse, how do they manage food allergies on the school bus and during after-school activities also. Then you want to make sure that if you have a child, I find about the fourth and fifth grade is probably the worst for bullying. If you know what the school's policy is about bullying and how do they handle that, and talk to the school nurse about the fact that you would like for there to be no bullying allowed whatsoever, and you'd like to know if your child is bullied and also what the repercussions would be for the child that is bullying your child also. So, and then I think it's worth while asking the school nurse, how do they educate the other students about food allergies? Do they have books that they read in the library, or do they have a video that they might watch, or is there an opportunity maybe for you to come in or your child to come in and help educate other children about food allergies so everyone's more comfortable about it? And then you want to know, how does the school nurse train the other staff? Does she physically go around to each teacher and make sure that they're able to use auto-injectable epinephrine? Do they see the coaches? Do they go to the PE teacher? All the different people that may be involved in your child's school day, who trains them and who checks to make sure that they can recognize anaphylaxis and that they can correctly administer the medication. Number 4, you should go meet with the food services. And by that, you need to plan, what are you going to do for lunch or snack or any of the other opportunities during the day for children to eat food. So I think it's reasonable to ask the school to consider posting menus in advance, allowing you opportunities to think about what may be safe foods or unsafe foods. I know that some of the public schools actually have automated systems where they will punch into the computer what the child's allergies are, and for that day it will sort of match what the ingredients are in the cafeteria. And as the child approaches the checkout, they give them their number and they look to say, no, you really shouldn't have that because of the risk for this food allergy contamination. When those kinds of things are in place, it certainly helps us feel a little bit more comfortable. But you need to think through all of the things that go into your child being able to eat a meal at the school. And then you also need to make sure that somebody in the school, hopefully the school nurse, or possibly even you yourself, may want to make sure that the food service personnel, you may just want to stop by and talk to the food service manager, but make sure they're aware of cross-contact reactions, that, simply using the spoon from one thing and then taking it over and stirring something else is a potential for cross-contact. And they need to think about surfaces and how they clean them and the risk for possible casual food contact that could cause an allergic reaction. And some schools actually will even post pictures of the children with food allergies, not out there for everyone to see, but in a place that could identify, this is a child, we need to be worried about this, and we need to make sure that we follow up in the food that they might get. And those are things that you might ask your school to consider in order to help keep them safe when mealtime comes. The other things that come up is where you're going to sit. There are some schools that feel like there needs to be a food-free table, that all the kids that have food allergies should sit at this particular table. In general, I don't make sweeping policies with my families. I usually try to think about what's the age of the child and what's the potential risk of the food they're allergic to coming in contact with in the lunchroom setting. Certainly, we're all very nervous when you have a class of kindergartners, and several of them may have ADHD and they don't remain in their seat and they run around the room while they're still eating their foods and they touch and grab everything. As a parent, that would make me a little more uncomfortable of having a food allergic child that may be in the midst of all that. So you have to sort of take all of those factors into consideration, and whether or not a food-free table or an allergen-free table is optimal or not. Certainly by the time we get to middle school or high school, those things are really not necessary. And I always try to remind families that Someone could be sitting right beside you and eating a peanut butter sandwich and you're peanut allergic, but the peanut butter is not going to leap through the air and come over and cause an allergic reaction. As long as that person who's eating peanut butter can keep their hands and their body and their food to themselves, that may be a low risk situation. But you have to think out all those things and talk about them when it comes time for mealtime. I think it's important to encourage good hand washing. Um, your child should wash their hands before they eat their food in case they've had cross contact with some food that would keep them from putting it potentially into their mouth. And it's always a good idea to wash your hands after you've eaten your food, too. And then we talk about washing the food surfaces um, where the food is going to be put down. Certainly, if they're using a tray that has gone through the hot water heating system in the kitchen, that surface is probably low risk. But if they're going to be putting their food down directly on a table and someone has eaten lunch right before them, then there is the risk potentially for cross contamination. And you need to think about ways to clean that surface before they eat. Sometimes it may be as simple as bringing a placemat where they put their food down on their own personal placemat, and that may help keep their space a little safer. We also know that if you're going to actually clean the surface, that dragging around a dirty rag with soapy water on it is not optimal, that really just sort of spreads the allergen all over the place. And we need some sort of a method where we mechanically wipe away the surface, throw it away, get something new. I usually like to think of, like, for example, Clorox wipes, and you should wipe, toss one, get another one, wipe, toss one, and those kinds of methods. I usually do that 2 or 3 times, would help sort of remove potentially any cross contact foods. And then the other thing you want to make sure is, where is the auto injectable epinephrine going to be in the lunchroom, and will the staff that's in the lunchroom, who may not be their regular teacher, it may be someone who's on lunch patrol, make sure that they're knowledgeable of what an allergic reaction is and how to use the auto injectable epinephrine too. Things that you should discuss with your child that I think is helpful if they're old enough to understand is that they shouldn't trade food with others. They should not eat anything with unknown ingredients, or if their particular label says may contain, even if that's a food that they normally eat at home, probably school is not the place for them to eat that may contain, because the risk and the situation of people that may be able to respond to an allergic reaction is a lot higher. You need to tell them that if they feel funny, their throat's itchy, or they suddenly have a significant concern that they might have eaten something that they shouldn't have eaten, that they need to go ahead and notify the adult immediately, so that they can get treatment more quickly. And we pretty much say that it's best to stay away from home baked goods, because it's really hard to control that kitchen too. Number 3 is go meet the teachers. I think it's very important that you get a sense that the teacher that is going to be having your child, either for even an hour, that they have some sort of understanding about what an allergic reaction is, and also that they would be able to use auto-injectable epinephrine if they need to. I think it's important for you to encourage them to create a safe classroom environment for the child. And then you also need to think about, well, what happens when that teacher is out? How will the substitute teacher know that your child has food allergies? And how will the substitute teacher know where your auto-injectable epinephrine is? Sometimes it's simple as putting it in their teacher planner book that they may pass down, or on their computer screen, and whatever their screenshot is that comes up, to remind whoever might be filling in that there's a child in that class that has a food allergy that they need to be aware of. Sometimes in the lower grades, it's important to even send a letter home to let other families know in the school that there is a child in the class that has food allergies. Sometimes they'll post signs outside the door. I think that if you have children that have food allergies in that classroom, that posting a peanut sign only is really not fair. If you have a child that has a milk allergy in that room too, or a wheat allergy, there should be no wheat, no peanut, no milk signs that are all posted outside of the door, or at least alerts outside the door that can remind parents that may be bringing in outside food, that this classroom contains a peanut allergic child, a milk allergic child, a wheat allergic child, etc. I think it's important to mention to the teacher that bullying is life threatening and that you would like for them to notify you if there's any bullying going on, and you would like for them to be very proactive and not allow your child to be bullied. And there should be a little bit of discussion about that, especially if there are kids that are bullies or being bullied for other things too. They're not fully understanding at how dangerous food allergies can be. So we need to target the bullies and make sure that they get educated too. So, other helpful classroom tips. You might suggest to the teacher that actually, if you could make the classroom a food-free classroom, that would be ideal. Now, I know in a lot of our school systems we have overcrowding, and that's not necessarily something that is possible. They have to eat in their classroom because there may be no other place to eat. But you should walk through that and see, can we maybe possibly isolate eating to one particular area of the classroom, or what are going to be the mechanisms for cleaning up after there has been food in that classroom. So much of what we do in our schools these days to reward good behavior or holiday treats or parties or whatever is very much centered around food. If we can find ways to not use food as a reward, and there are great tips available online at some of the websites I'll show you at the end, that would probably be optimal. And it may also help our families that may be struggling with some weight issues also, if food is not such a center focus of our school day. And also, when there are special things that are going on, we're going to order food from a restaurant, I think we probably should ask the teacher to notify us ahead of time so that we might be able to still let our child be included, but may be able to hand select a meal that we feel more comfortable with from that restaurant, or may even be able to guide the teacher to a restaurant that we think may be safer. And this is sometimes when we're doing, like in the upper schools or high schools or middle schools, multicultural kinds of learning about different countries and their different foods. Then sometimes they'll order from different restaurants, and you want to make sure that your child is safe, but also included if that's possible. And again, as I mentioned, hand washing does help remove the allergens. The other thing that I think is reasonable to ask your teacher is that she give you at least 3 to 5 days if there's some food that's going to be brought into the classroom, so that you can check out the food and you can call the manufacturer if you need to, so that you do have a chance to suggest alternatives and discuss safe food options for your child. I do know, though, sometimes that things happen spontaneously, and that may not be the case. So I think it's worthwhile to ask the teacher if maybe you can leave a special treat for your child that may be available. If everybody else is getting a cupcake, but the cupcake is a cupcake your child can't have, can you potentially leave Rice Krispie treats if they're safe, or some other alternative thing for your child in that class so they don't feel left out? The other thing to think about in the child that has significant food allergies, that a lot of our supplies that we use in the classroom can contain allergens. For example, I've had a few kids that have a severe wheat allergy, and Play-Doh, certain brands can contain wheat, and certainly in the younger kids where they roll the Play-Doh out over every single surface, or maybe they eat the Play-Doh. That may not be the optimal thing to have in that class, and you may want to replace it with a Play-Doh-like substance that doesn't have the allergens. Or some things like paints or soaps or art supplies, all of those could potentially contain the allergen. So you do want to just run by with the teacher what your food allergies are and what kinds of school supplies may contain those allergens, and ask her if there's some alternative that you can supply, or maybe they can swap out with another teacher and get a product that does not contain your child's allergen. I think reducing any allergen opportunities in the classroom would certainly make all of us feel a little bit better. I do want to mention just briefly that hand sanitizer is wonderful for killing germs, but it really doesn't remove allergens from our hands. if we're going to try and remove the food allergens from our hands, we need good old soap and water, and the mechanical washing away of those allergens is the optimal way to reduce exposure to those allergens. And then I do want to mention too, do you need to discuss with your school nurse or your teacher, are there any special plans that might be necessary for your child? The main two plans that we talk about are an individualized healthcare plan or an HCP. This is a particular document that discusses accommodations that would be made to help keep the allergic child safe in the school setting. And all students with medical conditions, including food allergy, may very well benefit from having a healthcare plan. The other thing that oftentimes comes up is a 504 plan. And the 504 plan is based on the 504 section of the Rehabilitation Act, which was a document that was actually given for children who have disabilities. And what it was a plan to make sure is that children with disabilities must be allowed to participate in both academic and non-academic activities, and that they need to have all the same things that children without disabilities are getting. And oftentimes, food allergic children fall under this particular law since food allergies qualify as an impairment of major life activities. And so oftentimes people will go ahead and get a 504 in place so that they make sure their child's school environment is optimized and keeps them safer too. And those may be documents that you may want to think about. Number two, I think you should plan for all the other times. There's 1,000,001 activities that go on at a school after school, especially in the middle school and high school age. And fortunately, the school nurses do actually get to go home at some point. And there may come a time when your child is still at the school and the school nurse is no longer there. So we also need to think about those other activities, including times when the child may be out on the playground, recess, or PE. In those particular situations, we need to think about, are those individuals trained to handle an emergency if it were to happen? And also, where is the auto-injectable epinephrine going to be located on that particular PE teacher or on the playground monitor? And how quickly can that be accessible if the child accidentally is on the playground and comes across a peanut and messes with it or eats it or whatever other thing might be outside, or perhaps maybe they have a stinging insect allergy and they get stung. We need to think about all of those particular situations. So we also need to think about, in the other group, transportation issues. What are they going to do if they ride the school bus? We think that probably the best policy on a school bus is a no food policy, that there shouldn't be any food eaten on the bus when there are food allergic children on the bus, unless there's a special needs child maybe that has diabetes and has to have food in those particular cases. And if food is allowed on the bus, perhaps we need to think about special seating. Maybe the food allergic child should sit closer up to the bus driver, where there may not be any potential for food contact. So we need to think about, is the bus driver able to recognize an allergic reaction? Do they have a cell phone that they could, or an emergency radio that they might be able to radio someone if the child were having an allergic reaction? And there are several school districts in our community that actually do training of all their school bus drivers in order for them to be able to respond to an anaphylactic reaction. But you need to think through those. How will your child get to school? And if they're going on the school bus, what special precautions do you need to take? And then the other considerations are, don't forget about the coaches. We mentioned the substitute teacher. And remember that the teachers for the after-school clubs. In my kids, in my practice that have clubs that they may belong to, or do a sport after school after the school nurse is gone, I usually recommend that either in their sports bag or their backpack, they pick a pocket on the front and they somehow or another label that pocket that their auto-injectable epinephrine is in there. It could be something as simple as putting masking tape across it and writing the word Epipen, or you could make some sort of a tag. Sometimes you can laminate a little tag and put a paper clip through it and put it on the zipper so that that zipper compartment contains the medication. And then I usually recommend when they go to the club that the first day that they show the coach or the teacher where they keep their medication and make sure that they are familiar with how to use it. And then one of the other things, again, that we think about is that sometimes kids with food allergy have a lot of social isolation, and we want to try and address those. We do the other stuff, want to think about field trips. And sometimes with some kids with significant numbers of food allergy, it might just be easier to go along in addition to the regular chaperones. Um, it should be important that someone who's planned the field trip has thought about, are there potentials for your child to have an exposure to a food on that trip? And if they are going to be taking special snacks, that they are appropriately packaged to not cross contact the other snacks that may contain the allergens. And again, before they eat, they should remember to wash their hands. And as always, we want to make sure that somebody on that trip knows how to use the auto-injectable epinephrine and knows when you would need to use it. I'm going to just briefly mention again, it's important again that we think about and ask our children, not every single day, but every so often, how do your classmates accept you or know about your food allergies, and make sure that they have opportunities to talk about times when they may have been scared or felt like that their peers really don't get their food allergies, and maybe taunt them or tease them, or just don't understand why they eat different foods. I think obviously the more we can talk to our kids about these situations, the better equipped they'll be able to handle being sometimes a little bit different, and also be able to talk about the individuals that are not treating them well. And this one I leave blank with a picture because there probably is no great for each of you, your vision of relaxing a little as the number one thing for a good school year may seem, after I've just mentioned all the things that potentially you need to think about, may be far from where you think you are. But as you know, children grow so very fast, and it's important to do your homework, get things ready, and then sit back and enjoy the year and enjoy this moment in your child's life. Not every parent is at the same place, especially if it's a new diagnosis. There's a significant learning curve that there's a certain amount of information you need to know before you can feel comfortable with your child at that school. And for some people, this is the very first time they've ever let anyone else take care of their child with a food allergy. And again, as we mentioned, there's a lot of misdirected fear of epinephrine. I think the most important thing is, as I talked about, building a team. You can have meetings and interact via email with different staff. I say this one point here about choosing your battles wisely. Sometimes if you go in there at every single thing, then sometimes you alienate the teacher or the school nurse. And then when you really need them to hear you about, valid concerns or things that are near misses or mistakes, sadly, sometimes they don't listen. So I think it's important to communicate, but at the same time, you need to have good, valid points that you're going to bring up and discuss, and also try to be rational if you can. I think volunteering is probably the best opportunity to show people, if you have free time, on how to manage food allergies and to educate people about food allergies in a non-threatening way. And I think that may be a good way to help educate people who are not very up to snuff about food allergies. I think anytime you can offer solutions instead of pointing out what the problem is, but offer, I realize that this is what's happening. Perhaps maybe we could try to do this. That may, in fact, help facilitate resolving the issue and also helping to keep your child safe. And I think you should check back periodically and make sure that there are still the same people on your team, or if new people have been introduced into the team somewhere along the way, that they are properly educated also, though. So let's review. What are the 6 steps for a successful school year? Number 6, get your stuff in order. Number 5, go talk to the nurse. Number 4, meet with food services. Number 3, meet your teachers. Number 2, plan for the other times. And number 1, enjoy and try to relax and have a great school year. Uh, I do want to just remind you that we do have some information that's available on our food allergy support group at the Tidewater website. We are getting ready to update some of that. I know some of it needs to get a little bit of a new vision, and that's on my agenda to do in the next few weeks. But there's some useful information there, and there's some more very good websites that are available. Obviously, I mentioned FAIR, which is foodallergy.org. The American Academy of Allergy, Asthma, and Immunology has some good information about food allergies. So does the American College of Allergy, Asthma, and Immunology, and some other websites that I enjoy looking to see what they have updated information about. Allergic Living magazine, allergicliving.com, has great resources and lots of information. And also Kids with Food Allergies has wonderful handouts and information that you could take to school and help educate the other individuals there about your child's food allergies. And also Anaphylaxis101.com, I think, is a great resource. So that's pretty much what I wanted to talk about today. So what I'm going to do is move back now to the beginning slide. Went over about 6 minutes. I'm sorry about that. And what I'm going to do is try to look to see what kinds of questions are in the chat room. And I'm also going to go ahead and stop the recording so that all of the chat questions aren't there on the FASGOT website.